Evening MRCP Part 1 aspirants. Today's the class is about infectious disease which would be conducted by Dr. Manmohan Bose. He's a consultant intensivist and in charge of AHRC hospital in Ranchi. His area of interest are as follows: nephrocritical care, neurocritical care, endocrine emergencies. Yes, sir, now you can proceed.
Good evening, all. I'm Dr. Manmohan, working as a senior intensivist at Ranchi. I finished my MRCP. I completed my MRCP thesis last year, 2022. I cleared my part 1 in 2022. So back to back, I cleared 1, 2, 3 in 2021, 22. Okay. So, and simultaneously, I cleared my EDIC as well. EDIC is an European Diploma of Intensive Care. Those who are from critical care background or those who are practicing intensives, they will understand what EDIC is. But EDIC is another way to get into UK, either MRCP or EDIC, which is both are eligible for GMC registration. So today's class is about infectious disease. Yeah. So I will read the question and it is going to be open discussion. I am not going to answer straight away. You have to type your answer in the chat box. I used to directly ask the answers, but then what happened? Those who are answering right answers, others will hear that, so that creates some confusion. So I want you to type your answer in chat box. I will just go through those chats and then see what is the right answer. Okay, so let's start. 13-year-old girl was taken to emergency department by her parents. She had 36 hours of history of nausea, vomiting, and abdominal cramps. On examination, she was afraid, but abdomen was tender with a guarding. 2 hours after admission, she received a specific agent, and after that, she passed large quantity of stool. The picture of the stool is given here. What is the diagnosis? Yeah, I want you to type. Yeah, anyway, I just click the slide, next slide. But yeah, I can see somebody has lumbricoides. Yes, okay. Okay, Moni, if you got it right, actually somebody said also in this. Nectar, yeah, Nizam Shah said nectar. No, it's not nectar. I want everybody to be an active participant of this class. Okay, so those even if you get it wrong, it's okay. If you get it wrong and then you understand the question, you will remember for till your exam gets over. Okay, so that is better. Yeah. So the answer is Ascaris. Okay, Ascaris is a large roundworm. It can go up to 35 centimeters. Most common nematode infection. It is one of the most commonest nematode infection. Symptoms developed after as a result of pneumonitis caused by the worm migration to the lungs. Obstruction is one of the rarest feature, but yes, it can present as a intense obstruction causing abdominal pain and all. When they give specific agent like a mebendazole or piperazine, they'll pass a large amount of stool, which will clear the obstruction and the pain will get relieved. Strangulate cercolysis is another common infection, but not as common as Ascaris. Okay, the symptoms could be pruritus as envisioned by the that. It can invade the lung, also can cause eosinophilic pneumonia due to passage into the lungs. Gastrointestinal, yes, common, but not as common as Ascaris. Nectar americans and Ankylostomia duodenale are hookworms. Their length is shorter than 1 centimeter. Okay, the major manifestation of chronic of this Nectar americans and Ankylostomia duodenale is iron deficiency anemia. Right, whipworm is a helminth approximately 4 centimeter. So this question, if you know the what is approximate length of nematodes, you'll get the answer right. Next question: a 66-year-old man present to the emergency department with 2 months history of confusion. There is no previous history of cardiovascular disease or peripheral vascular disease. He denies any history of fever or meningism. On examination, he was unfebrile. Neurological examination demonstrated ataxic gait and reduced coordination. Which of the following tests is most appropriate to help make the diagnosis of tertiary syphilis? How will you diagnose tertiary syphilis in this gentleman? I'm getting the answers. Yeah. Okay, keep on. There are 2 answers. Few more I want. Positive EDRF. Okay. Anything else? Aman has said TPHA. and that's a right answer. Yeah, A is a correct answer. So if you compare between VDRL and TPHA, TPHA is a treponema pallidum hemagglutinin test. So TPHA is better to a better test to diagnose tertiary syphilis. Tertiary syphilis can present up to 20 years after the primary infection. It can involve the mucous membrane like a gunmatter syphilis, cardiovascular system, or neurological system. Okay, so VDRL test is a antibodies test which can detect antibody to cardiolipin, which is produced as a responsible to trichomonas infection. It is very sensitive in early infection. In acute phase in primary syphilis, VDRL is a diagnostic test of choice, but its sensitivity declines in a late stage of infection. So it is not specific and may also give false negative in HIV co-infection. So in against to that, TPHA is a specific to treponema antigen, and therefore it is more specific. Both VDRL and TPHA tests are often positive in gunmatter syphilis. However, cardiovascular and neurological, TPHA test is better. Okay, cultures are time expensive. It takes longer than what we expect. So we want rapid diagnosis. So TPHA is always better. Spinal fluid samples may demonstrate positive VDRL and low glucose raised protein. However, the results are many times you will get inconclusive results. So if you ask me among all, yes, you will perform lumbar puncture as well when you are suspecting neurosyphilis, but that's not the only way to diagnose. If you ask me the better way to diagnose, it's TPHA. Question number 3, a 39-year-old lady presented to the general practitioner, 4-day history of fever, rigor, shortness of breath, cough, productive green sputum. She was diagnosed with HIV in her sexual health clinic 4 months before. She has not yet started on medication, though says that her HIV doctor suggested that she should start shortly. Her CD4 counts were 340. Her HIV viral load was 75,000. She has no other past medical history, and she doesn't take any medication. On examination, she is breathing heavily but cannot come, but she can complete her word sentences. Her respiratory rate was she's tachypneic 24 per minute. She has dullness on percussion and coarse crepitation and bronchial breathing at the right basal zone. Okay, her heart rate is 112. Heart sounds are normal, pure. GBP is not raised, and she has no signs of edema. Abdominal and neurological examination is normal. She is not confused. Her temperature is 38 degrees centigrade. Blood pressure is normal. Saturations are 97% on room air. Blood tests are taken and reveal. You can see the blood test. Would you like to go ahead with the question again? Because was it too fast for you, or you got hack up the question? I'll just give you 10 seconds extra to just read the question again. So she has fever, rigor, shortness of breath, and she's producing green sputum. On auscultation, she has a coarse crepitation and bronchial breathing at right base. She's tachypneic, tachycardic, febrile. Okay, and her blood pressure is acceptable, 100/55, saturation is 97. Her labs raised WBCs, creatinine mildly raised. Sorry, no. Urea mildly raised, creatinine is normal. Enzymes are okay. CRP is raised. Chest X-ray reveals consolidation at the right lung base. ECG showed sinus tachycardia. What is the best initial antimicrobial therapy for her? Answers, please.
Cotrimoxazole.
Cotrimoxazole. Okay. Any other answer? Just a minute. I'm going through the chat. Yeah. Somebody had said A, then B. Then probably somebody said Amman had said lobar pneumonia, probably C. Somebody had said D. C. Okay. Yes, majority goes with C. So how will you get the answer to this question? Let me go back to the first slide. Yeah. How do you grade the severity of pneumonia? This lady has pneumonia. Everybody agrees to that?
Yes.
Yeah. So how do you assess the severity of pneumonia? What is a score for to assess the severity of pneumonia?
Curve 65.
Very good. So what's her? So here you have to calculate the curve 65. You will get the answer. What's her curve? On the first slide, what is this curve? What is her curve? There are two slides regarding the question. Tell me the curve. What is a curve? She is not confused, so that is ruled out. Urea is on next page, so urea is more than 7 is a cutoff, right? So what's her urea?
Urea is raised.
See, you have to screen the labs. Okay, you don't get time in the actual exam. Here we are getting ample time to go through left and right, come back, and then again go forward. But in actual exam, you have to just screen the labs as fast as possible based on your scenario. So here the most important lab is urea. So yes, urea, yes, 1 score. What is the next R? R for respiratory rate. What is the cutoff for respiratory rate?
30.
30. So her respiratory rate is
24.
24. So that is not there. Okay, C is not there. U is there. R is not there. What about B? B for blood pressure. Is it there?
No, sir.
No. Okay. So among C, U, R, B, only U is there. Okay.
1.
Right.
Yes.
So what about 65?
No, there's urge.
Yeah. So her score is just
1.
But somebody said the blood pressure. Look at the blood pressure. What's the cutoff for the blood pressure?
90/60, sir.
So what about diastolic?
55.
So that's a positive, right?
Yes, yes, sir.
So her curve 65 is actually 2. And for that, the preferred drug of choice is like amoxicillin plus clarithromycin combination. Okay, the answer C is right. Majority of you answered C. So I just don't want to go to explanation straight away. I want you to create your thought process in the question itself. Okay, I want you guys to think your answer before actually reading the options. Okay, if you are able to do that before actually going to the option, if you are able to get your answer on your own before going to the options itself, max. And if you get the answer and if you are able to find that answer in your options, 95% of the time you'll get the correct answer. But if you read the question and without thinking your own answer, if you directly straight away go to the options, sometimes we get confused between options. Okay, there are 2 options which are very close. Sometimes you'll able to rule out 3 options, but among 2 you'll get confused whether it is A or B or B or C. So to delete that dilemma, what my senior suggested me to use a strategy, if you know the question, if you know what question it is about, if you know that topic well, before actually going to options, think about the answer and then read the questions. That will have a better clarity of answer, and the probability of getting confused between 2 options is less. So had you thought about her curve score before and curve score 2, would have got, many of you got it right. Okay, so answer C is correct. So her curve score was 2, as I said. One was urea, other was a blood pressure less than 60. So that's why, as per the British Thoracic Society, we will consider amoxicillin plus clavunet. Okay. Invasive pneumococcal disease 40 times more common in HIV compared to those non-HIV. Okay, but here it was a different. The lady will, yes, she is going to receive antiretroviral therapy shot, but unlikely at this count. Her CD4 count was more than 200. Okay, 340. Okay, so that's why the probability of fungal or tuberculosis was low. Okay, so that's why A and B was not right. And as per BTS, I said pneumococcal probability was quite high. So it is irrelevant to CD4 count. This is just community acquired pneumonia that can happen to anybody. Okay, ciprofloxacin has a poor gram positive, so it's not ideal choice. Chlorotrimazole, yes, appropriate treatment for PGP, not when the PGP possibilities at this count is minimal. Okay, if the count is less than 100, you have to remember the chart at what CD4 count a patient can have what infection. Okay, there is a chart, you can find it in cholera, you can search it on Google. At 200 they can have this infection, at 400 they can have this infection. If the CD4 count is less than 50 they can have. So there are categories, three infections they can have as per the CD4 count. So please remember that chart. You can get 1 or 2 questions regarding that. Okay, so as I said, option A was regarding TB, but unlikely in case of acute. Her history was quite short, so unlikely to be pulmonary TB. Histoplasmosis can cause pneumonia, okay, but it usually has a typical presentation. Here, this lady had a right basal patch, okay, everything was suggested on lobar pneumonia. There was a bronchial breathing also. So, and histoplasmosis has a diffuse patchy infiltration. Okay, so that's not a typical one. And it usually occurs when the CD4 count is less than 150 and unlikely without travel history. Next question, a 30-year-old gentleman who is again HIV positive presented to the ED. CD4 count, his CD4 count was 100. Here the chart is important, as I said in the previous question. His presenting complaint is of gradual onset, mild generalized headache, fever. He had 1 episode of vomiting. On physical examination, his febrile temperature is 38 degrees centigrade. He has no photophobia, papilledema, and there is a mild natural rigidity. Bearing in mind most likely diagnosis, what is the most appropriate treatment to commence following a diagnostic lumbar puncture? What diagnosis you are expecting at this CD4 count? That will give you the answer.
Diagnosis meningitis?
Yes, agree. But what meningitis? Viral, bacterial, tuberculous? That's the diagnosis. CD4 count is 100. It's a meningitis. Somebody has answered in the chat. Okay, I saw D. Any other option? Other candidates? So the positive thing in the question, she had to travel to USA. Okay, and now she had the signs of meningoencephalitis or meningitis. What is it? First get the symptomatic diagnosis and then you will get the exact diagnosis. As in the previous question, somebody said,
so can you show the options?
Yeah, let me go. Yes.
Meningoencephalitis.
Meningoencephalitis, very good. But so yeah, so you got the syndromic diagnosis. Now you get the pathogenic diagnosis, what bug it can be. Okay, so 2 things. So 2 positive things in the complete, such a big question, 1-page question, 2 positive things you will find out. One is she had a recent travel history, she is drowsy, and MRI is showing high intensity signals and swelling in bilateral thalamus. Where do you see this? Lyme disease. Okay, anybody else?
Meningoencephalitis is usually caused by some viral infections.
Yes, good.
Penetration is not possible for bacteria and.
So which virus? So what are the options here? Tell me, you're going in the right direction.
West Nile virus infection, maybe.
West Nile, good. So she had a USA travel. Okay, so it's one of the commonest infection you see in that United States of America. Okay, so that's the correct answer, A. Okay, West Nile encephalitis. So syndromic diagnosis was a meningoencephalitis. More than meningoencephalitis, you can say just viral encephalitis, and it is encephalitis, and the viral USA West Nile fever is one of the commonest. It is endemic thing. The incidence is quite high in USA. So there are few countries and few areas, like in India, malaria is common, tuberculosis is common. So when they mention travel history, and this kind of questions are particular for infectious disease system, when they say travel, please, so what are the diseases are common in that country? What are the diseases that are endemic? Like in India, it's malaria and typhoid rare, malaria and tuberculosis is very common. So when they say a UK citizen traveled to India for 2 weeks and then came back, then he had. So we have few questions regarding that also. So always think about what country they are talking about and what is the endemic disease there. So you'll get diagnosis accordingly. So subtle convulsive status, only manifestation which can be twitching and disease digit of the muscle group. Okay. The MRI scan are typical and travel history adds to the weights. So two things, as I said in the question itself, MRI and the travel history will give you the diagnosis. If you want to get a exact confirmed diagnosis, lab diagnosis, it's RT-PCR of CSF. Okay, interferon alpha is the only treatment which may affect outcome in the treatment of Western illness. So drug of choice is interferon alpha. Cystic fibrosis may predispose Western infection, probably due to disruption of blood-brain barrier. The absence of skin rash and normal biochemistry go against Lyme disease. Lyme disease can affect your LFT and RFT, so that is against the Lyme disease. And presence of reflexes and other absence of atypical changes will rule out GB syndrome.